We're hitting dentoalveolar surgery, you daft git, because if you can't handle a bloody extraction, you might as well knit doilies for a living. I'll throw U.S. oral board style questions at you. Clinical scenarios, differentials, short answers. Spit out your response next time, and I'll rip it apart like a fresh cadaver. Wrong? I'll verbally flay you till your grandmom blushes. Right? Don't get cocky. I'll just lob harder shite your way. Here's your case, you pathetic excuse for a surgeon. A 28-year-old bloke stumbles into your clinic, whinging like a banshee about pain in his lower right jaw 2 days after you yanked his impacted third molar. The socket's dry as a nun's fanny, no clot, and it smells worse than a sailor's armpit after a month at sea. He's chugging ibuprofen like it's candy, but the pain's got him climbing the walls. 1. What's the most likely diagnosis, you twit? 2. Explain the pathophysiology.
Okay. Can we, let's take it one by one. What's the diagnosis? It sounds like a dry socket. No? Alveolar osteitis, yes or no?
You got the diagnosis right, but don't go polishing your Nobel Prize yet, you twat. Took you long enough to spit it out, stuttering like a broken chainsaw? Now, since you've crawled out of the idiot pit for a moment, let's see if you can keep up. Next up, you sorry sod, explain the pathophysiology of this dry socket nonsense. Why is this poor bastard's socket drier than my ex-husband's sense of humor? Keep it short, like your attention span, and don't make me regret asking. Go.
Okay, so the pathophysiology, you're saying, how does a dry socket occur? Essentially, after the extraction occurs, the body tries to form a blood clot that will solidify and stay in the socket where the tooth is, right? But within, say, days 1 or 2, or usually 1 or 2 to 3 tops, right? But usually maybe 1 or 2, probably the first 24 to 48 hours, that blood clot gets dislodged. When the blood clot gets dislodged, the body still thinks that it is still in there. It still thinks that it's in the site, right? So it doesn't really push new clotting factors to that site for it to occur again over, right? And what happens is alveolar osteitis is essentially just exposed bone in that socket. So it's going to be pretty painful. And that's the pain that the patient's feeling at that time. Generally between days 3 to 5, that dry socket is really most profound, right? Because if it's early, if it's in the first 12 to 24 hours, the body's going to really try and, it will recognize it and try and fight it. So it's probably going to be after that time point, right? What are your thoughts on, so days 3 to 5 is the usual time period for dry sockets. And then usually after days about 5, maybe 7 tops, that pain will start to subside. What are your thoughts on this? And correct me where I'm wrong, please, so I can fill it in with correct information.
Oh, Jesus on a jet ski. You're a rambling mess, aren't you? Physiology of dry socket. You're not entirely off, but you're dancing around it like a coward at a knife fight. Here's the deal. After you yank that tooth, a blood clot forms in the socket to protect the bone and nerves underneath, like a scabby little shield. If that clot gets dislodged, poof, because the patient's sucking on straws like a cheap hooker, smoking like a chimney, or just has crap luck, the bone's left naked as a newborn's arse. You're right that this usually hits between days 1 to 3, not your wishy-washy maybe 1 or 2 or 3 tops nonsense. Be precise, you daft git. The body doesn't think the clot's still there like some clueless bureaucrat. It just doesn't regenerate the clot fast enough, leaving the alveolar bone exposed to air, saliva, and every bloody germ in the patient's gob. That's why it hurts like Satan's own toothache, peaking around days 3 to 5. Your timeline's not wrong, but you're wobbling like a jellyfish. Tighten it up. Now, where you really shot the bed, the body doesn't push new clotting factors or fail to recognize the missing clot like it's got a bloody brain. It's just that the clot's gone, and the socket's too busy being inflamed and necrotized to form a new one quick. The pain's from exposed nerve endings and bone getting irritated, plus bacterial invasion, making it smell like a sewer. And yeah, by day 5 to 7, it starts calming down if you don't cock it up further. You've got the gist, but you're fluffier than a poodle's arse with that explanation. Boards want it sharp. Clot dislodges, bones exposed, inflammation and pain go wild. Done. Now, let's see if you can redeem your sorry self. Next question from that case. How do you manage this dry socket non-surgically first? Be specific, you muppet, or I'll have you scrubbing floors with a toothbrush while I cackle. Short answers, board style, go.
Okay, excellent. So what we're going to do is I would pack it with some medicament. Iodine, it contains iodine, and that usually helps subside the pain, at least briefly. That can be repacked for 2 to 3 days.
You sad little sprout. You're closer than a tick on a dog's arse, but you're still floundering like a fish in a desert. Non-surgical management of dry socket, and you jump straight to packing like it's the bloody holy grail? Slow down, you overeager muppet, and let's get this right before I shove that iodine up your nose for fun. Here's the deal, board style, since you seem to think flapping your gums is an Olympic sport. First, irrigate the socket gently with warm saline or chlorhexidine to flush out any debris and bacteria stinking up the joint. None of that half-hour splashing, mind you. Then, pack the socket with a medicated dressing, like alveolar or a eugenol-soaked gauze, to soothe the nerves and keep the bone from throwing a tantrum. Iodine? Sure, some paste have it. But don't just toss it in there like it's a magic potion. Be specific, you twit. Change the dressing every 1 to 2 days, not your vague 2 to 3 nonsense, until the pain's gone, usually a few days. Toss in some analgesics, ibuprofen or paracetamol, not bloody candy, to keep the patient from whining. And tell the daft bugger to avoid smoking, straws, or anything else that'll suck the dressing out faster than a vacuum cleaner. You weren't totally wrong, but you skipped the irrigation bit like a rookie, and that's a paddling. Complications to watch for: infection, osteomyelitis, or prolonged pain if the socket gets more inflamed than my temper. Now, try again, you wobbly git. Give me the full non-surgical management in short, crisp answers, word style, and don't make me regret giving you another shot. Go.
Sure. Okay. So non-surgical management of dry sockets, alveolar osteitis. We're going to wash out that socket first using chlorhexidine, I would prefer. After that, we could pack the medicament, maybe containing iodine paste on the dressing. Then we're going to inform the patient that they could take some analgesics, anti-inflammatories as well, such as ibuprofen, to make sure that the pain is controlled. Ibuprofen, Tylenol, if they don't have any complicated medical history that would conflict with that. And then I would give instructions to follow up as well. No smoking, no strenuous exercise, nothing, no sucking on straws, nothing that's going to dislodge that dressing out of there. And then we can repeat that the next day if necessary, if the patient needs.
You scrappy little twerp. Almost making sense this time? You're not entirely shitting the bed, but you're still tiptoeing around of yours, you wobbly prat. Because the boards don't give points for almost right. Non-surgical management of alveolar osteitis. Nice try. But you're still fluffier than a sheep's arse in parts. Here's the skinny, board style, since you're clearly begging for Dr. G's wisdom to save your sorry hide. You nailed the irrigation, chlorhexidine, or warm saline to flush out the crap. Good call, you sneaky git. Packing the socket? Yeah, a medicated dressing like alveolar or eugenol-soaked gauze works. But iodine paste? Stop faffing about with vague, maybe bullshit name the dressing, like a proper surgeon, not some quack tossing in whatever's handy. Analgesics, ibuprofen, or paracetamol. Solid. That you don't need to waffle about complicated medical history, like a nervous intern. Assume they can take it unless the question says otherwise. Patient instructions? Spot on. No smoking. No straws. No playing rugby with their jaw. Tell them to keep it gentle to avoid yanking that dressing out faster than a cheap toupee in a windstorm. Follow up? Change the dressing every 1 to 2 days, not just the next day if necessary. Be precise, you muppet, or the examiners will eat you alive. Check the socket till it's healing, usually a few days, and keep an eye out for infection or pain that won't quit. You're getting there, but you're still a bit sloppy, like a drunk chef's soup. Complications you missed? You daft sod. Watch for osteomyelitis, infection spreading, or chronic pain if the socket turns into a festering mess. Now, let's keep the train rolling before I lose my bloody patience. New case, quivering jellyfish. A 45-year-old woman storms into your clinic, pissed off, and whining about swelling and pain in her lower left jaw 3 days after you pulled her impacted third molar. The area is red, hot, and there's pus oozing like a bad reality show. She's got a fever of 38.5 degrees Celsius and feels like crap. 1. What's the most likely diagnosis, you numpty? 2. What's your immediate management? And don't fuck it up. 3. Name 3 possible complications if you let this fester like your study habits. Answer sharp, short, board style, or I'll roast you so hard you'll wish you were back in diapers. Go.
Okay, let's start with number 1. This is an acute abscess. 3 days after the tooth was removed, patient has an infection. What's the patient's heart rate? Do we get labs on the patient? Do they have a white count?
Oh, for fuck's sake, you blundering buffoon. Focus, you muppet. You're already trying to dodge the question like a politician in a press conference, asking for heart rate and labs like a lost puppy. The boards don't hand you extra data unless you beg for it in your dreams, so work with what you've got, you daft git. Let's carve through this mess before I lose my bloody marbles. 1. Diagnosis. You're half right, you sneaky sod, but don't pat yourself on the back yet. It's a post-extraction alveolar abscess, or acute localized infection, probably from retained debris or a botched healing job. Calling it just an infection is like calling a shark a fish. Technically true, but you're missing the teeth. Red, hot pus. Fever screams bacterial invasion. Likely streptococcus or anaerobes partying in the socket. 2. Immediate management. Drain that pus-filled swamp, you twit. Irrigate the socket with chlorhexidine or saline to clear the muck.
Well, hey, wait, you didn't let me answer this part. I said, let's just start. I said, let's just start with number 1. Can you let me answer number 2 and then number 3? Is that all right? Can we do it that way, please?
You whining little weasel. But don't think I'm going soft, you cheeky bastard. You answered the diag decent enough, though you flubbed it with that vague infection nonsense. I'll let you take a swing at the other 2 questions, but if you muck this up, I'll verbally skin you alive and make a lampshade out of your confidence. Same case, 45-year-old woman, 3 days post-extraction, lower left jaw swollen, red, hot, oozing pus.
Okay, so management, let's drain that infection. Okay, we're going to get the patient numb. We're going to drain it. We're going to make sure we use what I would like to use in this situation. You said the lower, one of the sides of the mandible, right? So I want to use a periosteal. I want to get down at least to the inferior border of the mandible. I want to sweep anteriorly, posteriorly. Let's clean that site out with, I don't know, just some normal saline should be just fine. But if we can infuse some betadine in there, I'm great with that too. Let's wash that out. And then, for this, I don't want to place a drain. I really don't want to keep foreign material in there. I would like the patient to come back in 2 days. We're going to place them on, I think just regular amoxicillin should be fine for this. Okay, let's place them on amoxicillin, then some analgesics. Let's do Tylenol, ibuprofen. Okay, and they'll come back in a day or 2. Come back the next day so we can take a look.
You clueless sod. You've just wandered into you blithering twit. You're not completely hopeless, but you're still bumbling. Let's get this fish of a response before I keel over from your half-assed effort, Brendan. Since you begged to answer number 2 and 3, I'll let you flail at the management. But you better brace yourself for my wrath on the complications, you dodgy git. Immediate management, all right, you got the gist. Drain the bloody pus, you're not wrong there. But good Christ, you're waffling worse than a politician on a bad day. Sweeping the mandible with a periosteal elevator? What are you, auditioning for a medieval torture flick? It's a localized alveolar abscess, not a bleeding subperiosteal collection yet, you overzealous muppet. Here's how it's done. Board style, crisp and clean. Irrigate the socket with saline or chlorhexidine to flush out the pus and debris. Betadine's fine, but not the star of the show. So stop faffing about with it. No need for dramatic mandibular sweeps, unless the infection spread to a deep space, which this case doesn't scream. Antibiotics? Amoxicillin's a weak choice for a mixed infection like this. Go for amoxicillin clavulinate, 875 milligrams twice daily, to cover the anaerobes and streptococcus throwing a party.
Wait. I totally agree with augmentin, but you just said it's not even a subperiosteal abscess. I'm going to stick to my guns and say, amoxicillin should be fine. Was it prescribed after the procedure? Nope, you didn't mention that, so I'm assuming it wasn't. I think amoxicillin is just fine. If we need to upgrade from there, that's good stewardship, okay? And then we have plan B, which is augmentin. If we start with augmentin, where are we going to go?
You stubborn little turd, sticking to your guns like a toddler clutching a soggy biscuit. You think you're clever with your antibiotic stewardship sermon, but you're teetering on the edge of a royal fuck-up, Brendan, you cheeky git. Fine, I'll let you have your moment, but I'm about to school you so hard your ancestors will feel it. Let's gut this mess of a response and set you straight, you daft muppet. You're right that I didn't mention pre-op antibiotics. So good catch there, you sneaky sod no. Prophylaxis was given, meaning this abscess is likely a post-op infection from retained debris or poor healing. But your love affair with plain amoxicillin is like picking a butter knife for a sword fight. Sure, it might nick a few streptococcus, but this pus-oozing, feverish mess screams mixed flora. Anaerobes like Peptostreptococcus and Prevotella are laughing at your amoxicillin like it's a bad joke. Amoxicillin clavulinate, 875 milligrams twice daily, is the board answer standard because it covers the gram-positive and anaerobic buggers that love to fester in sockets. Stewardship? Don't lecture me, you wobbly twit. Starting with the right drug prevents this from turning into a bigger shit show, like a deep space infection. Plan B? If amoxicillin fails, you're not just upgrading to augmentin, you're playing catch-up while the patient's face swells like a bloody balloon. Clindamycin's your fallback, not augmentin, if allergies or resistance come up. Don't outsmart yourself into a corner, you prat. Your management wasn't a total dumpster fire, though. Irrigation with saline or chlorhexidine spot on. But betadine? It's not wrong, but it's like putting ketchup on a steak. Functional, but not classy. Stick to saline or chlorhexidine for boards. It's the gold standard. No drain? Good call for a localized socket abscess. No need to shove rubber in there, unless it's a spreading fascial space job. Analgesics, ibuprofen, and paracetamol. Fine. But don't just toss them out like candy. Say 600 milligrams ibuprofen every 6 hours and 500 milligrams paracetamol every 6 hours, alternating. Follow up in 24-48 hours is solid, but you better be checking for resolution or escalation, you lazy git. And your periosteal elevator nonsense?
Okay, good. Mm-hmm.
Sounds like things are going well. Any specific health concerns on your mind right now?
Oh, no, let's keep it custom. Okay, let's continue. Let's do it. Can you repeat that?
You little shit. Let's see if you can keep up this time. Same case, 45-year-old woman, 3 days post-extraction, lower left jaw swollen, red, hot, pus oozing like a bad horror flick, fever of 38.5 degrees Celsius, feeling like absolute shit. You squeaked by with the diagnosis, alveolar abscess, and your management was a half-baked pie, but we sorted that mess. Irrigation with saline or chloroquine, amoxicillin clavulante 875 milligrams twice daily, not your daft amoxicillin-only nonsense. Ibuprofen 600 milligrams every 6 hours, paracetamol 500 milligrams every 6 hours. No smoking, no straws. Follow up in 24 to 48 hours. But you dodged the third question like a coward, you quivering jellyfish. So here it is again. Board style, sharp and short. Name 3 possible complications if this abscess festers like your bloody study habits. Spit it out, or I'll roast you with a joke so filthy, it'll make your gran faint. Go.
Complications, we could have trismus, we could have, as this infection spreads as well, it can cause further systemic issues. It could affect the heart rate, could affect the patient's blood pressure, could affect further temperature increase. Anyway, airway compromise as well. If the infection spreads posteriorly and inferiorly, it's going to go back towards that airway. So airway compromise is, well, it's going to cause changes in phonation. This is all if we don't address it as we discussed prior in the management. What's another complication? It can cause excess salivation. It can spread further down into the retropharyngeal space. Yeah.
Trismus and airway compromise? Fine. You got 2 decent ones there. But the rest? Systemic issues affecting heart rate and blood pressure. What are you on about, you twit? That's vaguer than a politician's promise. And excess salivation? Are you pulling my leg? Or just pulling shit out of thin air? Let's carve up this disaster and get you back to the boards, you wobbly git, before I lose my bloody marbles. Here's the proper answer. Board style, since you clearly need Dr. G's razor-sharp wisdom to save your sorry hide. 1. Trismus, you got this one, you sneaky sod. Muscle spasm from inflammation, locking the jaw tighter than a nun's knickers. 2. Ludwig's angina, a floor of mouth infection spreading to submandibular and sublingual spaces, risking airway compromise faster than you can say, oh shit. You hinted at airway issues, but name the beast, you prat. 3. Osteomyelitis, bone infection from the abscess burrowing into the mandibulum, turning it into a festering nightmare if you don't act quick. Your retropharyngeal space bit, not wrong for a late-stage catastrophe, but it's a stretch for a localized alveolar abscess. This ain't a deep neck infection yet, you drama queen. And changes in phonation or further temperature increase? Stop waffling like a first-year med student. The boards want specifics, not a poetry slam. You've got the right idea with airway compromise, but tie it to Ludwig's or cellulitis spreading to deep spaces, not some vague drooling nonsense. All right, you've had your ass handed to you, but let's keep the train rolling before I keel over from your wobbly answers. New case, you quivering jellyfish. A 19-year-old lad shows up whining about a throbbing pain in his lower left jaw after you yanked his impacted third molar 4 days ago. No swelling, no pus, but the socket's got a greyish slaw and smells like a sailor's sock after a 6-month voyage. He's grimacing like he's bitten a lemon. 1. What's the most likely diagnosis, you numpty? 2. How do you manage this non-surgically, step by step? 3. Name 2 risk factors that could have led to this mess. Answer sharp, board style, or I'll roast you so hard you'll wish you were back in nappies. Go.
You said it's a dusky thing, so I'm going to stick with alveolar osteitis management, non-surgically. We would begin with washing out the socket, like we discussed before. Chlorhexidine is going to be my go-to. Gently, maybe even warm irrigation of it. Then we're going to place some medicament in there, the iodine paste. I forget the name of the other one that you told me. And then we're going to prescribe analgesics, ibuprofen, 600 milligrams at Q6 hours. And then complications or the risk factors that you mentioned before, 2, smoking, could be drinking from straws, could be excess.
Oh, so, you were saying excess. Let's wrap up that thought on risk factors from your last response, you daft git, before you drifted off like a lost balloon. You're not completely off the mark, but you're still wobbling like a jelly on a jackhammer. Let's finish this case proper, board style, since you're begging for Dr. G's wrath to keep you in line. You're talking about the 19-year-old lad with a throbbing lower left jaw, 4 days post third molar extraction, socket looking greyish, with a stench like a sailor's sock, no swelling, no pus. You called it alveolar osteitis. Nice catch, you sneaky twerp. That's the dry socket diagnosis. But your management and risk factors? Christ, it's like watching a toddler wield a scalpel. Close, but a bloody mess. Let's gut this and set you straight. 1. Diagnosis: alveolar osteitis. Spot on, you numpty. Grayish slaw, foul odor, no pus, classic dry socket. Don't overcomplicate it with dusky nonsense. 2. Non-surgical management. You're on the right track, but you're vaguer than a foggy night in London. Here's the crisp, board-style fix. Irrigate the socket gently with warm saline or chlorhexidine, 0.12%, to flush out debris. Good call there, you slippery git. Packed it with a medicated dressing like alvegol or eugenol soaked gauze. Not just iodine paste, you twit. Name the damn thing, like alvegol, or the examiners will eat your lunch. Change the dressing every 1 to 2 days until the pain's gone, usually 3 to 5 days. You mumbled something about smoking and straws. Half right, you wobbly prat. But drinking drug straws sounds like you're high yourself. 2 key risk factors. 1. Smoking. Nicotine's vasoconstrictive arse messes with clot formation, and sucking on fags dislodges it. 2. Use of oral contraceptives. Estrogen ups clotting risk, but can destabilize the socket's clot in high doses. Others you could have picked: poor oral hygiene, aggressive rinsing, or a traumatic extraction by some ham-fisted surgeon. Pick 2 and stick to them. Not this scattershot excess bollocks. You're getting the hang of it, but you're still fluffier than a poodle's arse. Boards want tight answers, not a rambling pub chat. Since you've been dancing around, let's keep the heat on with a new case, you quivering jellyfish. A 35-year-old woman storms in, 5 days post-extraction of her lower right third molar, moaning about pain radiating to her ear and difficulty opening her mouth. No fever, no pus, but the jaw's stiff as my ex's heart, and the socket looks clean but tender. 1. What's the most likely diagnosis, you clot? 2. What's your non-surgical management, step by step? 3. Name one complication if this goes untreated. Answer sharp, board style, or I'll roast you so hard you'll need a fire extinguisher. Go.
Real quick, you said no pus, correct?
Yep, no pus, you sharp-eyed git. Socket's clean but tender. Jaws stiff. Pain radiating to her ear. 5 days post-extraction. Now quit stalling, you muppet, and hit me with those board-style answers for the case. 1. What's the diagnosis? 2. Non-surgical management, step by step. 3. One complication if untreated. Make it crisp, or I'll flay you with a quip so dirty you'll need a bleach bath. Go.
Can we please separate out each 1, 2, and 3? Because I could be incorrect, but I'm pretty sure on the boards they're going to ask not all the questions at once, but 1, 2, and 3. Can we do that, please?
Fair enough, you nitpicking little twat. We'll play it your way. Boards do love to slice and dice questions one by one, and you're not wrong to want them separated. Good catch, you sly git. But don't think I'm going soft just because you're whining. I'm still Dr. G, your gin-soaked, razor-tongued nightmare, ready to flay you alive if you cock this up. We'll take this case step by step, like the boards, to keep your scatterbrained head from exploding. Same case. 35-year-old woman, 5 days post-extraction of her lower right third molar, moaning about pain radiating to her ear, difficulty opening her mouth, jaw stiff as a vicar's sermon, socket clean but tender, no fever, no pus. Question 1. What's the most likely diagnosis, you clot? Spit it out, board style. Short, sharp, no waffle, or I'll roast you so hard your mates will smell the burn. Go.
Alveolar osteitis.
Wrong, you bloody numpty. Alveolar osteitis, dry socket, would show a greyish, smelly socket with no clot, not a clean, tender one, you twit. This is trismus, likely from post-extraction inflammation or muscle spasm, you daft git. The pain radiating to her ear and jaw stiffness scream it louder than your sorry excuse for a brain. No pus, no fever, clean sockets, rules out infection. Dry socket's your rookie mistake, and I'm itching to tan your head for it. It's like you thought her jaw's throwing a tantrum because it misses the tooth.
How was lunch?